welcome to this webinar from the Institute of Economic Affairs. I'm Emma Revell, Head of Public Affairs at the IEA, and this evening we're going to be asking how the UK can work to plug the shortage of doctors in our National Health Service. The world's attention in 2020 has turned towards healthcare systems across the globe, with the most crucial shortfalls grabbing media headlines being in PPE and in ventilators. But as we move beyond coronavirus, hopefully, and begin to tackle the enormous backlog of health interventions delayed or cancelled because of the pandemic, a lack of doctors is going to become even more of an issue. Britain ranks 27th out of 36 OECD countries for the number of physicians per 1,000 people in the country. And at the same time, 30% of doctors in the UK are aged over 55, meaning the health service is sitting on a ticking retirement time bomb. The UK is also particularly vulnerable to disruption in the supply of doctors from abroad, because the UK has 1 in 3 doctors in the UK qualifying outside of the UK. That's compared to only 12% of doctors in Germany and 11% in France. This is on top of a current number of 12,000 unfilled vacancies for doctors. Aging populations and medical innovations mean survival rates following illnesses are ever increasing, and we need more doctors than ever. But there's estimated to be a shortage of 400,000 doctors spread across 32 OECD countries, meaning competition for doctors will be even more competitive, I suppose. I'm delighted to be joined this evening by 3 expert guests to discuss these issues. Mark Tovey is a freelance researcher who focuses on health issues. He graduated in 2016 with a first-class degree in economics from the University of Sussex and is the co-author of several discussion papers for the Institute of Economic Affairs on including one exposing the millions of pounds of taxpayers' money spent on lifestyle interventions as part of the foreign aid budget. And last month we published his latest paper, Is There a Doctor in the House?, which is the inspiration for this webinar today, asking how the UK can avert a post-pandemic staffing crisis within the NHS. Dr. Kristian Niemietz joined the IEA in 2008 and has held a number of different positions, but since 2018 has served as our head of political economy. Among many fine publications, he's the author of Socialism, the Failed Idea That Never Dies, which is our most downloaded publication, not just of 2018 when it was published, but also of 2019. More relevant to this conversation, however, in 2016, he wrote a paper entitled Universal Healthcare Without the NHS, working towards a patient-centred healthcare system, which considered what the UK could learn from social health insurance models across the world. And finally, he's just been able to join us. Paul Bristow is the Conservative MP for Peterborough and a member of the Health and Social Care Select Committee. Both of Paul's parents worked in the NHS, and he's spoken in Parliament since his election last year on the importance of valuing care staff at the same level that the British public already value NHS staff. So I'm going to let all of our guests speak for a couple of minutes, setting out their thoughts on how we can improve staffing within the NHS, and then we'll move on to questions. I'm sure our viewers are all very used to webinars run on Zoom by now. There is a Q&A box at the bottom of your screen, so you can put your questions in that box at any time. If you need a while to think of a question, that's absolutely fine, but keep the Q&A box open anyway, because you will be able to upvote any questions that you think.
Affected by shortage of doctors, as Emma said in her introduction, it's really a global problem. So if we want to be on the right side of this next global health crisis, we need to make some common sense, cost-effective reforms now. And I'm going to go through 3 problems that we can address in order to do this. First, we need to do away with professional protectionism. That is the idea that an individual must have a specific job title in order to fulfill a certain role. Now, the situation in some parts of the NHS is so ridiculous, and I can illustrate it with an anecdote. So a physician associate who I interviewed for my research for the IEA, she told me that she'd worked for many years in the NHS as a nurse practitioner and had been able to prescribe drugs. She then decided to retrain as a physician associate, which is an exciting new clinical role introduced by the government to plug gaps in primary care. And then suddenly she was no longer able to prescribe drugs, even though she'd been doing it for decades. safely, legally, and effectively, she had to ask her colleagues with the correct job title to sign off on all her prescriptions for her. So we have to kick out jobs worths who stand in the way of non-doctor clinicians upskilling and assisting overburdened doctors with their jobs. Similarly, in the same vein, biomedical scientists, these are support workers who help histopathologists, that is doctors in labs, they should be trained up to be able to report on the stage and grade of tumors by slashing cancer waiting times. 2 decades ago, before this type of support worker was introduced into labs, it was unthinkable anyone other than a doctor should be able to cut up and dissect tissue samples. Now it's routinely done. So why not extend their role still further, given the chronic shortage of histopathologists? The second point, the second problem, and it's closely related, is this idea, which is sadly too prevalent in the NHS, that everybody must travel down the same training pathway. Every year, universities churn out 60,000 biological science graduates, and these young people, despite having studied biology and chemistry for 2 years, they can't apply to postgraduate training courses for frontline clinical roles like in extended nursing posts. And it's simply because the government hasn't worked out a framework for regulating people in these kinds of posts, if not through the Nursing and Midwifery Council. So it seems like the government thinks it makes more sense to spend millions and millions every year on wild goose chase recruitment trips to the Philippines and India to tap into this homegrown pool of talent. And third and finally, I think it's important to see that doctor shortages, they're concentrated in certain regions of the country and in certain specialties. An important question, if you're trying to understand doctor shortages, to ask is, why is it that specialties like histopathology, emergency medicine, psychiatry, year after year fail to persuade enough junior doctors to sign up? And the answer is that it's an entirely predictable consequence of a Soviet-style centralized system of wage setting in the NHS. Currently, Health Education England dictates the wages, setting largely similar rates for all specialties, all regions of the country, varying mainly with years of experience, kind of on a scale. And as a result, junior doctors have no incentives to apply for the undesirable specialties, and instead they all fight over the sexiest ones like neurosurgery, public health medicine. And if they don't get them, maybe they defer a year, go off to Australia, try again the next year. So sadly, it's just a case of naive socialist ideals, namely that all doctors should be paid similarly, triumphing over basic economics. And anyone unlucky enough to suffer from a disease which requires the attention of a shortage specialty doctor will pay the price. And with that, I will hand over to Kristian.
Thank you, Mark, and thank you all for joining. I'd like to talk about the big picture first. Liberal critics of the NHS often describe it as a centralized, top-down bureaucracy. They see it as a miniature version of the Soviet Union. And when we're talking about the NHS itself, that is actually no longer true. The NHS has changed quite considerably over the past 2 decades. And in particular, it has changed in a more market-like direction. The Blair government, is in particular, in its last years, brought in various market-based reform measures. For example, they extended patient choice. As a patient, you now have a much greater degree of choice than people used to have historically. And they also brought in a new payment system under which money follows patients. And that means that healthcare providers, hospitals, and so on, do to some extent compete for patients. And then they also gave most hospitals a much greater degree of independence by converting them into semi-autonomous trusts. And in that way, the NHS has actually moved away from this old Soviet-style way of doing things. So if you want to compare the NHS to a historic model of an economy, it would not be the Soviet Union. It would be more something like the Socialist Republic of Yugoslavia, where they had this system that they called market socialism, which means you have public ownership, you don't have much of a private sector, but you don't have central planning, you don't have 5-year plans. Instead, you have these state-owned entities having to compete for customers, and that's not a million miles away from what the NHS is like today. Now, what does this have to do with the topic of today? Well, the trouble is that from this market-based reform agenda of the 2000s, the medical labor market has been exempt. That was just completely left out of that. And there it is still absolutely true. As Mark said, there it still very much works along Soviet lines. There is not really a medical labor market as such in Britain. Pay and work conditions, working hours and so on of doctors, nurses and other healthcare workers are not set by supply and demand. They're not set by market forces. They are set by a points-based system of sorts, where the different, pretty much like a points-based migration system, except much more complex and much more fine-grained, where various professions in the NHS are grouped together according to variables such as skill levels, experience, and responsibility, things like that. And then a payment level is assigned to each of these groups. And then there's not much flexibility around that. So that very much is a Soviet-style system. If you had a Russian who still remembers the Soviet Union, or an East German who still remembers the GDR, working in this wage-setting bureaucracy, they would feel very much at home there. They would think, oh, this is just like in the good old days. And so this is the strange thing, that we now have this hybrid system. We have Yugoslavia-style market socialism in the provision of healthcare, but we have medical labor market that is still organized according to old-fashioned, more conventional Soviet-type socialism, and they just don't fit well together. And in workforce planning, therefore, we get the problems that we always get in planned economies. You get a massive oversupply in some areas and shortages in others, and no obvious mechanism to balance them out. Then you get the problems that Mark described. So the solution would be to just bring the medical labor market into line with the way the rest of the NHS is now organized. The rest of the NHS has moved on. Why can't the medical labor market? So I would phase out national pay scales. I would reduce the role that the central government plays in this area. And I would just treat every NHS organization as an employer in its own right, meaning that they can negotiate with their employees or their representatives, and they can just work out pay, working hours, work conditions. They can come up with their own criteria, who they want to admit, for what sort of qualifications they want to demand. That can then be along the lines that Mark describes in his paper. My guess is that in a lot of cases it would be, because it sounds eminently sensible, but it wouldn't have to be that particular solution. I would leave that up to them. If some of them want to do things differently, that would be fine too. And the main thing would just be to phase out the role of central government, phase out national pay scales here. And I guess, I don't know how exactly you would do that, but I suppose one could learn quite a bit from the university sector, because there we see a lot more variation and between universities, and there you don't see these strict boundaries between professions within higher education that Mark described do exist in the NHS. There's a lot more movement across these boundaries. Why not use that as a starting point?
Thank you very much, Kristian. Paul, if you are able to unmute yourself, we will have some opening comments from you. Thank you.
Well, thanks very much, Emma. And I've got to say, I was mightily impressed with the contributions of the last two speakers. This is actually music to my ears, because this is something I've been wrestling with and talking about for some time. And I was going to start the presentation by talking about government commitments and how many extra nurses have been recruited and all that sort of stuff. And I can still do that, but I think it'd be rather more useful than just to give you a little bit of insight of some of the things that I've been talking about before I became an MP in my previous job of running a political consultancy. So just a couple of things. I think what the coronavirus pandemic has done, it's shown how the NHS has been strong and has been valued. But I also think it shows and has exemplified some of the areas that the NHS has struggled and some of the pinch points in the NHS where it is struggling, and it's exemplified these. So, for example, waiting times, I think GP appointments, I think integration of social care in the NHS, but also in workforce planning. And I think that's been, quite evident. And I think one of the things that we can look to try and improve all this is, I've got three things that I've scribbled down. The first is productivity, second is hierarchy, and the third is culture. I think one of the positives, before I come on to these three problems, I think one of the positives has been that despite the fact we've always told one another how much we all value those who work in our NHS, doctors, nurses, etc., this is a vocation for many people. It's more than just a job. And I think the very fact that so many people stood outside their homes and clapped NHS workers is an incredibly positive thing for recruitment levels in the future. And you have seen large numbers of people either returning to the profession or interested in joining the profession, I think probably directly as a result of some of the value that's been attached to the NHS from the general public. And in fact, I think UCAS figures are significantly up, which can only be a positive thing. But as the two speakers have said before, unless we kind of reform the way NHS workforce, some of the fundamental features of our NHS workforce, then I think we're still going to struggle. And the three things I've identified are productivity, hierarchy, and culture. So what do I mean by productivity? Well, someone once told me that we've seen 3 years worth of innovation in our NHS within 3 months. And people might say, well, only 3 years. Well, the NHS is an inherently conservative organisation and suffers from it's not invented here sort of attitude and sort of culture. And the fact that new technologies, new pathways, new systems have been adopted is a positive thing. And that's also happened in workforce, because you've seen, for example, in endoscopy, you've seen lots more nurse-led endoscopy. You've seen lots more not junior, that's not the right word, but not consultant, formerly things that were consultant-led being ran by non-consultants, which I think can only be a positive thing in terms of improving NHS productivity. I think Mark was absolutely right that quite often you've seen a number of situations where professions in our NHS have been reluctant to expand knowledge of procedures and in other areas, and there's been a sort of closed shop conservative mentality. I'll give you an example. Mechanical thrombectomy is a procedure that can remove clots of stroke victims. It has the potential to be absolutely revolutionary in how we treat stroke patients, primary PCI was for heart attack patients. And it could massively increase results for patients who suffer from stroke. And a form of interventional radiology was neuroradiology. And the neuroradiologists were protectionist over this new technique, thinking that only neuroradiologists should be able to perform this technique. One problem, there's only 80 of them in the whole of the UK. There's nothing, if you want to create 24/7, because you don't have a stroke from 9 to 5, Monday to Friday. If you want to have 24/7 mechanical thrombectomy service across the whole of England, you would need interventional cardiologists and interventional radiologists to be upskilled to take on this procedure. And that's happening, but that came with a lot of resistance from neuroradiologists, thinking that only they had the skill in order to provide this procedure. But if you can remove a clot in your coronary artery, you can remove a clot in your carotid artery or in the arteries in the brain. And I think that's been clear. And thankfully, that problem has been overcome through political will, actually, more than anything. And I think that's a very good thing. But that's an example there. Secondly, in terms of hierarchy. Now, a lot of people talk about the NHS being a wonderful place to work, and it is for many people, and their experiences are very good. Though I've been acutely aware that there's an increased amount of accusations of bullying and intimidation and all sorts of other things within certain NHS trusts and structures. And someone asked me the other day why they thought that was. And I think a lot of it is because the NHS doesn't really have a flat structure. As one of the other speakers said, I can't remember which one, I think perhaps Mark, that there are lots of people, lots of different titles, lots of specializations, lots of people, and this creates a hierarchical structure of so many layers and complexity that often, you know, people are in their own little silos, but are answerable to so many different people in different ways. There's not a flat structure where people have the freedom to come up with ideas, new ways of doing things, new ways of working that you might see in many private sector organizations. I think one of the ways that that's beginning to change and has changed in certain areas is that patients are sometimes consulted or looked after by what are called multidisciplinary teams in certain specialisms. So for example, in vascular surgery, someone who may have intermittent claudication or critical limb ischemia may be seen by a diabetologist because they may have diabetes, may be seen by an interventional radiologist, a tissue specialist. So all these different sort of professions may sit down and consider a patient and consider their needs. And that is a much more flat structure where that patient will get the actual right diagnosis for them and will be seen very, very quickly. But that is not always the case across the NHS. And I personally want to see many more multidisciplinary teams and a much more flat structure when discussing issues around individual patients. And finally, I talk about culture. Now, I kind of touched on that earlier when I talked about protectionism of particular procedures and particular areas, but it goes further than that. I have had enormous fun in my previous kind of role going to lots of different NHS professional symposiums and lots of NHS professionals society dinners and things such as that. Now, you know, I had a good time. I met lots of very good people doing lots of wonderful things, but I can imagine how that might be off-putting to so many people who are just starting out. It is very much a system where one looks up to those people who have been eminent in their profession for a number of years. And lots of people have worked incredibly hard to get to where they are. But the way these symposiums and these professional societies sometimes have been run, I think, are culturally much more like perhaps private members clubs in St James's than really areas where you would want to kind of disseminate learning and best practice, especially if you're a junior consultant or a junior doctor coming in. And it may especially be off-putting for females or those from Black and ethnic minority backgrounds. And that's just me observing from the side. Many people might disagree with me, but involved in those. But I think sometimes the ability to question those who have been in a particular field for a number of years is particularly limited, especially within professional societies. And, you know, something younger clinicians, you know, may have better ideas, new ways of doing things, and have developed through a period of time new structures within their own departments or even new techniques. And we shouldn't be conservative in trying to adopt new techniques, new ways of working. So those are just three things that I see as potential barriers to widening the number of people entering into profession. Because what we're talking about here at the end of the day, in terms of doctors and consultants, are very, very often very specialised and niche areas, and they tend to suffer from these three problems as a result.
Thank you very much. We've touched on an awful lot of different issues. I think if we pivot slightly to the solutions, I mean, one aspect that the UK has relied on in the past to plug a shortage of homegrown doctors, as it were, would be to compete internationally for doctors. And as I mentioned in my introduction, you know, 1 in 3 doctors currently working in the UK has trained abroad. But as healthcare systems across the world improve and become more attractive, you know, the prestige of working in the NHS to a foreign doctor is lessened. How important do you think international recruitment will continue to be? And how can we make sure the NHS continues to be an attractive place for attracting foreign doctors as well as homegrown ones? If Kristian, you can start, because I know alongside all the things you've written about the NHS, you've also written a lot on UK immigration policy.
Yes, I was going to say that is more a matter of immigration policy really than healthcare policy. That would just be that's why well, one reason why I think ending freedom of movement now of all times is not a brilliant idea. But I don't want to bang on about Brexit. I want to sort of move beyond that. But
we're allowed to mention it once per webinar, so that's Brexit
once per
done.
webinar. Okay, yeah, that's that. Yeah, I would certainly have kept free movement for a couple more years at least, and then see how it goes. And otherwise, yeah, I think the government is already broadly on the right track. A lot of medical professions are on the shortage occupation list, which means that the conventional thresholds in the points-based immigration system are lower. It is easier to come to the UK if you want to work in healthcare. Most medical professions are already pretty much on this fast track list, and that is the way to go. I don't see a huge problem there for recruiting beyond the European Economic Area, because yeah, it is true that of course you will have a lot of emerging economies becoming relatively prosperous in the coming decades, and there will be less of a push factor for immigration. But I think English-speaking countries will always have more foreign-trained doctors than most continental countries, for the simple reason that English is the lingua franca in international medicine, and that's why Britain and Ireland have options that, say, Finland doesn't have.
I wanted to point out there that we already have some questions in the Q&A. I'm going to continue to abuse my privilege as chair and ask a couple of my own, but please feel free to pop your questions in the Q&A and I'll move on to those momentarily. Paul, you talked about some of the challenges, to recruiting and maintaining staff. What do you think are some of the hurdles to change? Kristian and Mark have talked about, perhaps we need to allow medical professionals to upskill within their own jobs, or allow more devolved pay setting. Do you think those things are politically feasible?
I think politically within Westminster and within ministers and NHS England, I think that's entirely achievable. I don't think there's any substantial barriers to those things here. I think the problem will come from culturally within the NHS and within professional societies. I talked about that issue about interventional neuroradiologists. I think that's that sort of protectionism is a huge issue. And I think the solution to those problems, I mean, they have been overcome in the past, because I think when you've seen new techniques coming to certain areas, there's been a lot of resistance and cultural resistance from people who have been opening up and cutting patients open for a number of years. And there's been huge cultural resistance to newer keyhole techniques and lesser invasive techniques. But those have been overcome because the evidence came. Now, I think as a result of the pandemic, there's been certain pathway changes and certain things have happened, such as nurse-led endoscopy, nurse-led services in other areas. And certainly I think you're going to see a significant number of people administering the coronavirus vaccine, who perhaps previously wouldn't have been able to administer vaccines. But you'll see more junior staff, and I keep using the word junior, that's not the right word, but staff other than consultants doing things, which I think is inevitable in a drive to try and increase NHS productivity. And I think that will be only a good thing. I think Mark talked a little bit about that as well. But in terms of the other things, I think what we really need is a real fundamental change in how the NHS is structured in terms of hierarchy. So that means that adoption of multidisciplinary teams I talked about, much more. And I think in terms of the culture, I just think we need to bring some of these professional societies and some of these professions into the 20th century, let alone the 21st.
If we could get those on board, we would be halfway there. Mark, I think Paul made a very good point there that I actually hadn't thought about, is that the coronavirus vaccine is going to see a lot of people who wouldn't necessarily have been delivering vaccines prior to 2020 trained up to do that. We're already using the army, for example, to man testing centres. So people who wouldn't ordinarily have these skills are having those skills. Do you think the pandemic is going to push people towards that solution that you proposed in your paper, that more medical professionals should be allowed to do different things?
Yeah, it's a really interesting point, and I think we all hope that the pandemic will make the NHS more open to reform. I mean, the medium-term view for the health service is grim, isn't it? I mean, lockdowns have eviscerated the tax base on which the health service depends. At the same time, demand on health services is growing all the time due to pre-existing secular trends like aging populations. And the IFS forecast that there could be a million extra people with chronic illnesses related to poverty as a consequence of lockdowns. So yeah, there's going to be huge pressures on the NHS and huge pressures to innovate in order to meet demand. And that's a great point you made about how the government has moved in recent months to amend the human medicine regulations to allow, I think, paramedics, pharmacists, a whole host of allied health professionals to be able to support the COVID vaccination program. So yeah, I think that is a positive sign, which suggests, and as well the nurse-led endoscopy example that Paul gave as well, another great example of how the pandemic could push the health service into being a bit more open-minded about what type of professional is required for different tasks.
Kristian, I'm going to address this next question directly to you because of the work you did. I mentioned the Universal Healthcare Without the NHS paper. One of the anonymous attendees has asked, are there some specific examples of countries that have been successful at changing structure and hierarchy, the sort of issues that Paul notes? Are there countries that are better at that than the UK, and could we learn lessons from elsewhere?
Well, that's the thing. In the systems that I'm talking about in Universal Healthcare Without the NHS, those issues would not be political issues, or at least not to anything like the extent that they are here. If individual healthcare providers want to structure themselves differently, if they want to have flatter hierarchies, if they want to be more open about professional boundaries, they would have greater freedom to do that. And it wouldn't require a political reform necessarily. It wouldn't require a health secretary who is sympathetic to that. It would just be something that develops on the ground. And therefore, you wouldn't even necessarily know about it. It's not something that would be discussed in newspapers. It would just be like when a company in car manufacturing or any type of industry restructures its business practices, it would just not be a political issue. I think that is broadly the lesson. I can't point to a specific reorganization or restructuring. I would just say the lesson from more market-based systems is that in those systems, it is up to the individual healthcare provider how they want to structure themselves, and you don't need a sympathetic health secretary, a sympathetic government generally. You can just do things differently and then have a bottom-up process, see what works.
It's a feature of the system we've ended up with, I see. Paul, this next question I'm going to put to you because it will allow you to say good things about the government's commitment to hiring new nurses. But there's a question from Jonathan in the chat that says, medicine is a very competitive university course, which is massively oversubscribed. What does the panel think of solving the shortage of doctors in the UK by increasing supply through private medical schools like the newly opened Buckingham University Medical School?
Well, that could only be a positive thing. And as I said earlier, I think there's been a 16% increase in the number of UCAS applications for medicine. So when the government does talk about increasing the number of doctors and the 50,000 extra nurses, they really do mean it, and they will be held to account for that at the next election. But I'm convinced that we won't see the impact of that unless we deal with some of the structural challenges which Mark and Kristian have outlined, and indeed myself. Just another thing I think I should talk about. We talked about the number of foreign overseas doctors and nurses coming to the UK. I just think for too long we've kind of been addicted to that pool of people from abroad, and I'm not suggesting that we just turn it off at the taps, because I think that would be that wouldn't be very good at all. And as I think Kristian said, that's an immigration matter. But we do need to get much better at recruiting our own doctors and nurses and NHS professionals. If we don't, we'll continually be in this problem. And I think the government are serious about it. As I say, we've seen that increase in UCAS applications, but this can't be a short-term fix. This is going to take perhaps a number of years to address.
This is very true. I mean, as the questioner said, medicine is it's a very oversubscribed course because it's very popular. And Paul, as you say, it's actually the coronavirus and the outpouring of support for the NHS is probably going to make it more popular as a career path for students. Another anonymous question in the chat says, could a doctor's shortage be a result of increased demand in medical care due to the low cost for patients? So people seeking advice for minor issues from a doctor or even going to A&E when actually it could be dealt with by a pharmacist or over-the-counter medication. I think the implication there, possibly, I may be reading too much into this, but if we charged people for doctor's appointments, would they be a bit more inclined to focus their medical need on the right kind of person? Well, I wondered if the panel could share their thoughts on that, perhaps if we start with Mark.
Well, I suppose that I don't have the statistics to hand, but of course you hear that there's a great number of hours wasted of GP time with patients who are not serious, who maybe turn up just because they're lonely and they want to have a conversation, or maybe for some other reason which really doesn't require the attention of a GP, which is, of course, is very expensive per hour for the NHS. But I don't think it can be entirely down to these kinds of trivial abuses of the health system. And we see massive waiting lists for very serious procedures. And I wouldn't want to suggest that it was entirely the result of trivial inquiries from patients.
This is very true. I'm sure doctor shortages is some large factors and some very small ones all adding up into a cumulative problem. One question that I had on my list on the impact that the coronavirus will have on the appetite for NHS reform. This could go one of two ways. We either see that the pandemic focuses international views on global healthcare systems. How much in 2019 were we looking at the performance of the French or the German healthcare system, whereas now we're obsessed with the figures in all of these other countries. So is the pandemic going to lead to people understanding that there are other ways to run healthcare services, and therefore maybe the NHS could be opened up for improvement? Or it goes the other way and the clapping on the doorsteps leads to a doubling down of we must protect our precious NHS, and all reform is a threat to the NHS. Kristian, I know this is something we've discussed on IEA podcasts before, but if you wouldn't mind just reiterating your view on which of those two ways you think it might go.
Yes, I think on the podcast back then, I still said it could go either way. Yes, you have this increased defensive-ness about the NHS, the rally round the flag effect, which in Britain meant the rally round the NHS effect during the pandemic, with people becoming more protective of the current system, but also an increased interest in how are other systems coping and how are they performing. I think it's clearly the first of these effects that is going to dominate. There was greater curiosity. You could see in mainstream newspapers who wouldn't normally talk much about alternative healthcare systems suddenly mentioning them, and that's a positive development. But that is, I think, more of a niche phenomenon that is still limited to people who follow this very actively. But for most people, it's been an increased protectiveness of the NHS, and I haven't seen much discussion, for example, of the fact that Britain had the second highest excess death rate in the developed world, which to me suggests that the NHS has not been coping brilliantly. That after Spain, no other country has had such a large number of people dying over and above what you would normally expect around that time of the year. And also the increased rationing, that is not something that I'm aware of is happening elsewhere. That waiting lists for specialist care and elective surgery has gone up from something like 8 weeks to more like 20 weeks, almost half a year. That is quite astonishing. And you have people who have been on a waiting list for more than a year now. It's in that sense, it's been quite grim. And this has to be where a lot of the excess deaths come from. That I mean, a lot of people have made this case that the National Health Service has effectively become a national COVID service, and but yeah, that has happened. Conventional healthcare has been almost crowded out, ground to a halt in a lot of areas, and in these ways, I would say no, the NHS has clearly not been a brilliant performer, and that's where I would like to see some discussion about and some awareness. That would at least be a starting point, acknowledging that no, the NHS has absolutely not been a star performer, and for all the clapping, we don't seem to get much in return.
Paul, I mean, as I said in the introduction, you sit on the Health and Social Care Select Committee. How much do you think politicians are willing to look at international healthcare performance during the pandemic and say, okay, we didn't get everything right. There are some things that we can learn looking at other countries.
I mean, I think what Kristian said was slightly unfair. And I think quite often when you're comparing international examples, you're sometimes comparing apples with pears. And, you know, there are not, all the time, there are not distinctly comparable data sets you can use. I think it's fair to say that some of the areas where the NHS perhaps face challenges were some of these structural problems that the NHS has faced for a number of times. Like I said earlier, integration with social care. So we saw a lot of deaths in the social care system for one reason or another. I think you saw issues around GP appointments, which has always been a problem in parts of my constituency. You sometimes have to wait 3 weeks anyway to get a GP appointment, and then again on waiting lists. You know, you've seen a fundamentally challenge on waiting lists. But I think the NHS did cope. It didn't. We didn't see scenes like we saw in Italy and perhaps Spain, where people were treated by the side of the road. And I think there has been some phenomenal achievements. The way the NHS Nightingale Hospital was built and hospitals were built, and how capacity drove itself up. An ambitious deal was signed with the independent sector, which would have taken many years of political wrangling normally, but that was done, pretty quickly and conventionally because it had to be. So I think the NHS can feel kind of proud in many ways for the way it managed this. However, I think the NHS will require reform. It always requires reform. Any huge organisation always requires almost continual reform. But because it has to, because there are certain areas that were showing up that need reform. And I think that's going to be in productivity, as I said, about ensuring that but other staff can do jobs which are sometimes reserved for consultants. I think we'll see different pathways adopted. So previously, where we've done something because we've always done something this way, I think you'll find innovative pathways, often using new technology or new things. I think we need to embrace that sort of change, and I hope to see that happen. And I think we need to see more innovation used in our NHS. When I mean innovation, I don't just mean Zoom, kind of people doing things like this. I'm talking about more health technology. But I think things like this will help, things like GP appointments, because, if I've got an outpatient appointment at the Royal Free, it's pain in the backside. I can't park, I can't drive there. I'm still in, kind of relatively young. I'm, 41, but, I don't need to go all the way to the Royal Free and see someone. I can see a consultant much easily like this. And I think the NHS will have to adopt and reform in some of the ways I've identified, because it has no other choice. And another way is integration as well. The NHS has, I think, been shown to operate many ways in silos, and that's certainly not very satisfactory when it comes to managing a pandemic or a modern healthcare system. So it will reform because it has to.
There's a question here which touches on some of the points, Paul, that you've already raised from Sunny Thasu, I think. I apologise if that's completely wrong. Who says that they have spent 13 years in the NHS as a surgeon, and their comment says one of the issues is that any changes to the NHS is the various bodies such as the BMA and the General Medical Council who are resistant to their monopoly being challenged, which is then compounded by the narrative pushed by the Labour Party and others, and certainly a narrative we're familiar with here at the IEA, which is that any change to the NHS has to be part of a secret plan for privatisation. How can we overcome this? Mark, we'll start with you because I can see you nodding along.
Oh, well, yeah, it's an excellent point. And take, for example, the introduction of physician associates, who I mentioned earlier. These new roles, they were intended to fill GP shortages in primary care. And these professionals exist somewhere on the skill spectrum between doctors and nurses. It's a profession that we borrowed from the United States. They've been a thing over there since the 1960s, I think, but we only introduced them very recently here. However, as our commenter said, what was the name of this person? Sorry,
Sunny Thasu, I think.
Oh yeah, okay. Well, as they said, the BMA and the NMC predictably saw this job role innovation as a threat to their funding, as a threat to their training opportunities, and as a threat to their prestige and position. And it's just all too easy for these big unions to claim that the evil Tories are undermining our saintly NHS, and the press and the civil society fall for it. They readily believe these ideas. And I think, unfortunately, professional protectionism, this idea that job roles should just stay the same as they always have done and no innovation should take place. This culture finds fertile soil in the UK because even the slightest hint of a betrayal of doctors or nurses is just politically very toxic. And I imagine even more so now than ever due to what a sacred cow the NHS has become during the pandemic.
Paul, would you agree with that? Have you got any thoughts on, how we could possibly tackle professional organisations who are resistant to change? Because, at the end of the day, they're trying to protect their members' interests, but it perhaps is in the interest of the country and the wider NHS that they are more adaptive and more open to change.
I mean, I think there's a very fundamental point, and I made it myself several times. There's this inbuilt conservatism and resistance to change within certain NHS professions and within certain professional societies, and that does need to be overcome. People need to do different things. NHS professionals need to do different things and need to open up their specialties, and I think that will happen. I'm more optimistic than perhaps Mark is, because I think that will happen because it has to happen. And we won't have the comprehensive NHS that we all want unless we do improve our productivity. And I do look at organisations like the BMA and some of the more professional organisations. I do sometimes liken them to clubs in St James's of the past, resistant to open their doors to women and new kind of professionals. That will ultimately happen because newer recruits will come in and demand their place at the table. They don't just want to spend X number of years doing the same procedures over and over and over and over again. They will see the benefits, I hope, of change, of much flatter structures and improve productivity. If we don't, we'll be left behind because not just other health systems across the world will develop, it's just technology will develop. And sometimes makes, I use the examples of vascular surgeons and interventional radiologists. Those vascular surgeons who've gone on and done incredibly well are the ones that have actually adopted new interventional procedures and started doing those interventional procedures themselves rather than resisting and wanting to cut people open. That's the way. Science will prevail and innovation will happen.
I'm going to combine a couple of questions actually in the interest of time because we've only got 10 minutes left. One comment in the Q&A says digital health tech can be part of the solution to the workforce shortages. However, in order to work in healthcare, firms have to navigate a complex landscape. You know, we've got clinical commissioning groups, providers. I'm going to use a lot of these acronyms that I will admit I don't understand. FTPs, ICSs, ARCs. It sounds complicated even just from the acronyms. So to combine that with another comment from Chris in the chat box, how are we going to get rid of the NHS's crazy bureaucracy and waste of money? So also, one, to save money and streamline the NHS, but two, also to make it easier for providers and digital health services who want to link up with the NHS. How can we make it easy for them to navigate it? Paul, again, we'll come back to you. Sorry.
Well, I would say now is the time. Now is the time for those who supply the NHS to make the case for their innovation or their way of doing things and how it improves productivity. You will persuade the NHS to adopt technology and innovation by showing the NHS that they can achieve their own objectives by doing what you want them to do. And I mean, the person is absolutely right. The questioner was absolutely right. There are so many different organisations within the NHS who may have a procurement or a commissioning role that sometimes you don't have one customer, the NHS. You have, you know, kind of hundreds and hundreds of different trusts who procure different things. But I think now the time is to show how your product or your piece of technology or your way of doing things can help the NHS become more productive. Because someone did say to me they've seen 3 years of innovation within 3 months, and that's had to happen just because of this coronavirus pandemic. New ways of doing things, new technology adopted, and new systems adopted. You know, gone are the days of faxes and scribbles on paper. I think now is the time for procurement, but it's also going to be reasonable procurement as well, because the NHS is a notoriously bad customer as well. And sometimes, if I'm being completely honest, the industry can take them for a ride by charging them different prices in different parts of the system. Now, you know, some people might turn around and say, well, do you know something, that's the market and the NHS needs to procure locally. But that's when you end up with this complex system of 200 odd different customers all buying at different volumes. So the NHS needs to learn to be a better purchaser as well, and a better customer, so it's able to procure that value. And I think a lot of the things that has happened recently is designed to do that, such as getting it right first time and other systems too.
I mean, you do say there that the days of the fax machine are gone. I remember a report a couple of years ago from your colleague Alan Mack, which he published alongside the Centre for Policy Studies, which included in its introduction the detail that the NHS was the world's largest consumer of fax machines in 2017, to the point where doctors were having to resort to exchanging personal information about patients on WhatsApp because fax machines were breaking. The parts don't exist anymore because, as you say, who's buying fax machines? The NHS is famously slow to change, and that does illustrate that point quite nicely. Mark, I just want to throw to you for a second, because we had a question quite early on in the discussion that I've left till the end, which says, do you agree the evolution of the emergency care practitioner is a perfect example of the sort of thing you're talking about, how the NHS can be improved by giving greater responsibility to its existing workforce? The question goes on to say, for example, they can now prescribe medicines for their patients without the need for the patient to see a GP or an A&E doctor, which frees physicians up. So, I mean, there are examples of this happening within the NHS, but how optimistic are you that these aren't just isolated examples, that actually we will see this kind of upskilling?
Yeah, that's a fantastic example, and there are many more. I mean, but there have been movements in this direction. Really, the watershed moment was in 2005 when independent prescribing rights were given to nurses. And after that, there were physiotherapists added, paramedics, pharmacists, even dietitians were given the right to prescribe on a supplementary basis quite recently. But one factor that seems to be really holding up progress is just the process of amending the human medicines regulations. For example, the process of getting independent prescribing rights for paramedics, it had all been agreed by the union, so you can't blame it on, you know, the various medical unions. It in the end, an administrative oversight on the part of somebody at the Department of Health, which led to the legislation being delayed by 3 years. And so, you know, things like that, really, we need to ask why it is that we've had physician associates going back again to them, because they're sort of the figurehead of the government's workforce plans to help with primary care. How is it that we've had physician associates for so long in this country, maybe over a decade now, without going through the process of making them independent prescribers in law? And as I said in my introduction, we've got examples of former nurse practitioners who had the right to prescribe, who were prescribing perfectly safely, who now have to, you know, go and knock on the door of the GP and ask for a signature, or even knock on the door of a nurse and ask, of a nurse practitioner, and ask for their signature. You know, it's demeaning to people who want to try these new exciting roles that they haven't been given the status of independent prescriber. And yeah, I would say the same could be done for clinical psychologists as well. We have a massive shortage of psychiatrists in this country, huge backlogs for waiting lists for mental health services. So why not provide training pathways for clinical psychologists who are interested to study pharmacology and to be able to prescribe psychotropic drugs? It's just legislative barriers which stop it from happening, and a lack of action on the part of the government.
We've only got a couple of minutes left, and I do want to make sure I finish on time. So I'm going to be very unfair to a person who has asked a question, in that I'm going to steal the gist of their question, but not ask it in spirit. What they asked is, would each of the panelists rate out of 10 Matt Hancock as Secretary of State for Health? I think that is very unfair, so I'm not going to do that. But what I am going to do is borrow an idea from our Live with Littlewood weekly discussion show and ask how optimistic our panel are out of 10 that we will be able to implement the kind of changes that we've talked about today in the next, say, 5 years. So we'll go in the reverse order from the introductions. We'll start with Paul. How optimistic are you that things will get better?
Well, I am optimistic because, as I kept saying, I think the NHS will reform because it needs to. We focused a lot, as I said, on the area where the NHS was perhaps found to be short, and it's only been found to be short in the areas where I think it was already struggling. Like I say, in terms of integration, in terms of GP numbers, in terms of waiting lists. But the NHS will reform. But it's also shown some remarkable successes and remarkable ways and remarkable levels of resilience, which I just think shouldn't be forgotten. I also think that the extent of the elective waiting list is so large that the NHS will have to reform in order to deal with it. You can't just throw money at this system and hope it will. It will require extra capacity. It will require new ways of doing things. It will require new productivity. And I am enormously optimistic this will happen, because I think that an NHS bill will be presented next year. I'm not suggesting that is the golden ticket to resolving these problems, but I think if it focuses a lot on integration, it may start to resolve these problems. You've asked at the start about how would you rate Matt Hancock out of 10. I think Matt Hancock understands these challenges and is dedicated to resolve them. He also, I think, very heartily understands these issues around productivity and innovation. And in those regards, I'd definitely give Matt Hancock 10 out of 10, knowing that he's going to resolve those problems, because I think he understands them, which I think is first and foremost that we can ask for from any Secretary of State for Health. How he's performed during the pandemic, or what's happened during the pandemic, is completely different. Although I think he did a good job, and the NHS overall has done a good job because it's survived. But that's different from, I think, him understanding where the NHS needs to go.
Yeah, the issues facing the NHS go beyond coronavirus. We are going to run very slightly over time, but Kristian, very briefly, how optimistic are you that these things might get implemented?
Well, somebody said in the Q&A, the problem is that politicians quite rationally shy away from fundamental reform because they know that whatever they do, and especially if it's something that isn't well understood, somebody will say this is an attempt to privatize the NHS and to introduce the US-style system. This is a sinister attempt to sell it to Donald Trump. Oh, well, that's now gone, but they will find some other boogeyman. And I think that the pandemic has only strengthened that by the clapping rituals and everything that we've seen. I think this is here to stay. This scaremongering rhetoric, and it's going to work. So in terms of optimism, no, that's got to be a 2 out of 10. Sorry.
Mark, come on, balance us out. Paul is optimistic. Kristian is not. Split the difference for me.
Well, in terms of the kinds of reforms we've been discussing today, I think we have to be fair and acknowledge that there have been movements in these directions going on for decades now. Of course, in this year now, the economy lies in tatters. Demand on health services is just only going to keep going up and up. So I suppose if you want to be optimistic, you could say that that is going to force people's hand and maybe make these innovations happen more quickly than they otherwise would have done.
I will take that as a tiny amount of optimism. That's all we've got time for. Thank you very much to all our guests for joining us, and to Mark, Kristian and Paul for joining me this evening. Don't forget to visit the IEA website, iea.org.uk, and subscribe to our weekly newsletter, which will give you a heads up on all of our future events, publications, live streams. And if you particularly enjoyed this or any IEA webinars that you've been tuning into over the lockdown, you can also make a donation to support our work in future through the IEA website. Thank you very much.